On behalf of the SELECT Consortium, I want to present here data from our study about implications based on the risk of seizures after ischemic stroke. In people with stroke, apart from stroke-related deficits, the risk of seizures may also impact the ability to drive. Driving is often considered an integral part of life. Restrictions on driving may affect an individual's independence, employment, and quality of life. People with epilepsy and those at risk of unprovoked seizures may be subject to driving restrictions. Thus, we analyzed data from a multi-center, international cohort, including 4,452 adults with acute ischemic stroke and no prior seizures. We calculated the change of occurrence of a seizure in the next year provided with COSI. According to the SELECT 2.0 prognostic model, we considered COSI below 20% safe for private and less than 2% for professional driving, aligning with commonly used cutoffs. The SELECT prognostic model was developed by Marian Gelovich, the senior author of this paper, and was recently updated to a SELECT 2.0 prognostic model by Lucia Sinka. The SELECT scoring system was designed to predict the risk of seizures following a stroke by evaluating a comprehensive set of clinical and diagnostic criteria. It involves 5 parameters: severity of stroke, large artery atherosclerotic etiology, early seizures, cortical involvement, and territory of middle cerebral artery involvement. With these variables, we can calculate a SELECT score from 0 to 13 points, adapted to the patient characteristics, and calculate the risk of a late seizure from 0 to 60 months. Current restrictions on driving for people with epilepsy and those at risk of unprovoked seizures primarily rely on seizure-free intervals, often overlooking the underlying causes and individual characteristics. Thus, we calculated the COSI according to the SELECT 2.0 prognostic model. We found that seizure risks in the next year were mainly influenced by the baseline risk stratified according to the SELECT 2.0 score and to a lesser extent by the post-stroke seizure-free interval. I want to highlight this with 3 examples in this figure, where you can find the seizure-free interval in months on the X and the risk of unprovoked seizures in percentage on the Y-axis. In the first example, we take patients without acute symptomatic seizures who can get a SELECT score ranging from 0 to 6 points, which can be translated into a COSI from 0.7 to 11% directly after stroke onset, not affording any seizure-free interval for driving. In the second example, we take patients with acute symptomatic seizures, who, according to the SELECT prognostic model, can get a SELECT score from 3 to 13 points. 3 months after stroke, a COSI ranging from 2 to 92% can be calculated, showing a huge inter-individual variability. The same is true for the third group, people with status epilepticus, who get at least 7 points with the SELECT model and can reach up to 13 points. Their COSI after 3 months ranges from 14 up to 92%. We concluded that personalized prognostic models like SELECT 2.0 may offer better guidance for post-stroke driving decisions than generic seizure-free intervals. Our findings provide practical tools, including a smartphone or web-based application, to assess seizure risk and determine appropriate seizure-free intervals for safe driving. Clinicians, particularly those specializing in stroke and epilepsy care, will find this information valuable to make critical decisions regarding an individual's ability to drive or to perform specific jobs and activities. Regulators will use the data to devise evidence-based guidelines for driving after stroke. This could lead to a paradigm change in assessing the ability to drive after stroke. With this, I want to end and thank all the co-authors of this paper.